everyone. I'm Dr. Sadiya Khan.
I'm Don Lloyd-Jones.
And I'm Mitch Elkind.
And today we're here talking about cardiovascular kidney-metabolic health, the new Prevent Cardiovascular Risk Calculator, and the relevance those have for stroke, specifically stroke risk prediction, patient care, and research. The Prevent Risk Calculator is now available online at professional.heart.org at Professional Heart Daily. I am the Magerstadt Professor of Cardiovascular Epidemiology and an Associate Professor of Medicine at Northwestern University Feinberg School of Medicine, and I chaired the writing group for the AHA Scientific Statement, Novel Prediction Equations for Absolute Risk Assessment of Total Cardiovascular Disease, incorporating cardiovascular kidney metabolic health.
I'm a cardiologist and the chair of the Department of Preventive Medicine here at Northwestern University Feinberg School of Medicine, and I'm also a past president of the American Heart Association. Cardiovascular kidney metabolic health, or CKM health, is really foundational to advancing cardiovascular care, and it's relevant to stroke prevention as well. For that reason, we're very happy to have Mitch Elkind with us. Mitch?
Thanks, Don. So I'm a vascular neurologist and epidemiologist and professor of neurology and epidemiology at Columbia University in New York City. And I'm also a past president of the American Heart Association and currently serving as the chief clinical science officer of the American Heart Association. And from the American Heart Association point of view, cardiovascular kidney metabolic health is really a new way of looking at cardiovascular risk factors. And of course, any of these cardiovascular risk factors are potentially related to stroke. And so we think it's really important for the stroke community to know about this new approach to disorders that focus on obesity and diabetes and other cardiovascular risk factors.
Before we dive into the conversation, let's set the stage and define what we're talking about with cardiovascular kidney metabolic health, or the CKM syndrome. This construct was defined by the American Heart Association in a presidential advisory this past October. And as Mitch mentioned, it's really trying to bring together this clustering and co-occurrence of metabolic and cardiovascular and kidney conditions that often co-occur. Specifically, we defined CKM syndrome, or cardiovascular kidney metabolic syndrome, as a health disorder due to connections among heart disease, kidney disease, diabetes, and obesity that together lead to poor health outcomes. So with that in mind, we're excited to start the conversation, and later we'll wrap up with a look ahead at what's next for CKM and cardiovascular and stroke risk calculation.
So that's great, Sadiya. I think CKM syndrome really helps many different types of clinicians to frame the conjoint risks from obesity, diabetes, kidney problems, and ultimately cardiovascular disease. So it's an incredibly important subject, and I think a great way of framing this important prevention topic. The current prevention paradigm is really to think about all the risk factors that go into what could possibly lead to future cardiovascular or stroke events. And one of the ways that we think about risk is to calculate actual 10-year risk equations so that we can see, is this a person we would consider to be at high risk, where we might want to be more intensive with our preventive therapies? Yes, lifestyle, of course, for everybody, but actually maybe also including some of the medications that we use to prevent heart disease and stroke risk and events. These equations, these calculators, are actually very finely tuned to the population so that any clinician can actually use them to look at a patient's global risk factors. We're talking about things like cholesterol, blood pressure, presence of diabetes, in some cases, yes, the presence of obesity as well, but also past history, things like, was this patient a smoker? What's their age, sex? What's their current conditions? Where do they live? All of these things can actually play a role in a patient's near-term and long-term risks for cardiovascular disease and stroke. So these are quite valuable tools for starting a conversation with our patients about whether we need to consider things more than just lifestyle factors, and perhaps think about a statin medication, or for some patients, an SGLT2 inhibitor to really modify and lower their future risk for cardiovascular disease and stroke. So Mitch, should stroke doctors worry about these equations and this CKM syndrome construct as well, or is it too late for stroke doctors to think about prevention?
No, I think it's super important for the stroke community to also think about prevention. Don, I've watched over the last decades, I think, as you've worked so hard on the various risk prediction schemes that we have. And it occurs to me that in the old days, let's say, originally, the risk prediction algorithms were really designed to predict primarily coronary events. They predicted heart attacks and sudden death and so forth. Stroke was actually left out of those equations in many cases. And several years ago, I think it was kind of a change to introduce stroke into those algorithms as an outcome as well, which to me, as a stroke neurologist, makes a lot of sense because thinking of it from the patient perspective, they don't know at that point what the event is that they're going to have in 2 years, 5 years, 10 years, and so forth. And so it could be a heart attack, but it could also be a stroke. And the old way of looking at it by excluding stroke, I think, didn't really capture that risk. So now stroke is part of the overall outcome spectrum. I think we'll hear a little bit more from Sadiya in a moment about some other outcomes that are now included as well, like heart failure. And I think overall, this just makes these prediction schemes much more valuable, and certainly more valuable to the stroke physician as well. Just on the other point about, should the kidney aspects, metabolic disorders be included as well? I think absolutely. The evidence is growing that kidney disease and different forms of kidney disease are associated with an increased risk of stroke and other brain health related events. So real important for the whole stroke, and I would say neurology community, to know about these risk algorithms as well. Let me kick it back to you, Sadiya, to tell us a little bit more perhaps about what the risk calculator is, what PREVENT is.
I think you and Don very nicely defined the fact that our overarching principle in terms of applying a risk-based prevention approach, whether we're talking about stroke prevention or we're talking about heart attack prevention, or I think now importantly talking about heart failure prevention, is really the same. So that foundation still exists, that in order to best treat our patients, we want to identify who's at highest risk. And so that's where we really want to prevent to be able to better classify patients more precisely and accurately, classify patients who are at risk for cardiovascular disease, taking into account some of the things we talked about in terms of kidney function, metabolic health, and other things. So what is PREVENT? PREVENT stands for Predicting Risk of Cardiovascular Disease Events, and that acronym PREVENT equations were derived in 25 data sets of over 3 million people and then validated in completely different data sets in over 3 million people. The models are sex specific. They use age as a time scale. So importantly, they give not only 10-year estimates, as we were talking about earlier, but also extend that time horizon to 30-year estimates. And importantly, account for heart failure as an outcome. So we're talking about stroke, we're talking about coronary heart disease, and heart failure. By including these kidney and metabolic measures, we're more accurately assessing risk, particularly for patients who may be at higher risk because of poor kidney health or because of poor metabolic health, really underlying this construct of cardiovascular kidney metabolic health. The age inclusion was also extended, so the equations can be used for people 30 to 79 years. And importantly, race was excluded as a predictor. So we focused on making sure that we had a large volume and diverse sample for the derivation of the equations, and then explicitly testing the validation in diverse samples so that we can make sure that we really appropriately assessed the equation's calibration or accuracy and prediction in the overall population as well as in specific racial and ethnic subgroups.
Yeah, it's such an important point, Sadiya, to talk about the impact of race on cardiovascular disease in general, and particularly stroke, right? So I think this community, the stroke community, knows that certain race ethnic groups in the United States are at disproportionately high risk of cardiovascular disease and stroke. Interestingly, I don't know if Don and Sadiya know this, but the risk is actually greater for stroke. The disparities are greater for stroke than they are for cardiovascular disease. So Black populations, for example, have about 30% higher risk of cardiovascular disease in general, but it's almost 50% higher for stroke. So that impact is greater for stroke, and it's probably largely due to disparities in hypertension itself, which is such an important risk factor for stroke, and of course can also be driven by kidney disease. So really important things that we're talking about today. These increased risks are not only present for the Black population, we also see in the Hispanic Latino population, for example, an increase in risk, some variability in data there, but many studies have shown that, and certainly the American Indian and Alaska Native population as well, increased risks of stroke. Now, it's not just the increased risk of stroke. As I mentioned, there's increased risks of stroke risk factors in many cases, certainly hypertension, obesity, diabetes, all the things that the CKM paradigm is focused on are more prevalent, common in the Black and other specific race ethnic groups. And beyond the occurrence of stroke itself, we know that the treatment of stroke in many instances is not the same in those populations as it is in the white population. For example, access to acute care and care after a stroke, like treatment for depression after stroke, for example, or pain syndromes related to stroke, occur less often in the Black population than in whites too. So it happens at multiple levels. A big part of this is likely access to care, access to health insurance. Rates of being uninsured are more than twice as high for certain race ethnic groups, particularly American Indian, Alaska Natives, Hispanics as well, as they are for the white population. And so at so many levels, we see the impact of race disparities. And that's why I think it's so important that you've taken such a thoughtful approach in the prevent risk algorithm to how we address race. So, Sadiya, I was hoping you could say a little bit more about what that approach is in prevent and what it means to take race out of the risk algorithms. Why are we doing that? How does that work?
Thanks, Mitch. I think the statistics you provide really focus our efforts in this area, and that thought behind how we incorporate race into risk prediction or risk algorithms generally. The point isn't that we want to ignore racial disparities. We know they exist. And in fact, we want to address the risk and understand better what contributes to that risk. And so what we really wanted to better understand was, what are the risk factors that may be included, specifically related to social determinants of health, environmental factors that really race is a proxy for. And perhaps that's maybe why we have seen it be included in prior iterations of risk prediction equations, where it is representing a proxy for lived experiences and potentially racism, discrimination, and other social determinants of health. During our conversations and trying to determine how we should approach race and the lived experiences that it may represent, we wanted to think about how other specialties had considered this. And there is a growing consensus in medicine to really ensure that we are using race as a social construct. And we've seen it been removed from equations to predict kidney function, to predict pulmonary function in other areas as well, because it may unintentionally perpetuate disparities. It may unintentionally implicate that race is a biological predictor or factor and is causal in these health outcomes, which we know is not true. I think, Don, maybe you could provide us some background as well on how it was approached for the pooled cohort equations, and really why it's so important to ensure that we're not exacerbating disparities when we remove race from the risk equation.
Yeah, thanks, Sadiya. This is a really important topic, and I think the group was particularly thoughtful about how we should think about race in designing the new prevent equations. 10 years ago, when we were designing the pooled cohort equations, we didn't have some of the sophisticated research that has gone into how can we explain these race disparities, these differences in risk that relate to race but aren't caused by race. These are not genetic underpinnings that are differential risks. As Mitch pointed out, what we tend to observe in the population is that the associations of risk factors with outcomes are pretty universal, no matter where you live in the world, what your heritage is, what your genetic background is. The relationship of hypertension to stroke is very constant. What differs, I think, in populations is the prevalence of hypertension. And so we know that, for example, Black Americans have much higher rates of hypertension than white Americans do, and that tends to drive these disparities. So it's not race per se. As you said, Sadiya, that's a social construct. It's the things that race travels with, especially in this country, that create these health disparities, create these inequities. 10 years ago, when we were designing the pooled chord equations, we didn't have other things that we could use to represent that race disparity. And so we created race-specific as well as sex-specific equations to try to predict and account for those disparities in atherosclerotic cardiovascular disease, that's coronary heart disease, and stroke outcomes. Now, some researchers, as they should, kind of dug into this, and they noted that perhaps the pooled chord equations were overestimating risk, maybe especially at the higher end, if we care, but overestimating risk among Black Americans. That might have led to additional prescription of medications if that overestimation was occurring and influencing decision making. I think going into the development of these new prevent equations, we were very thoughtful about, okay, should we try to eliminate race from these equations? Because again, we don't want to suggest that race is a biological construct. It is a social construct. And given these universal associations of risk factors with cardiovascular disease outcomes, can we get rid of it? Can we replace it? And so the group really tried to, I think, be thoughtful about finding other things that could represent the lived experience, the social determinants of health, and the environment in which people are trying to live their lives and live their best cardiovascular health. And so, as you can talk about, we settled on the social deprivation index, which really does represent the environment in which someone is living and may indicate, whether they can actually have access to healthcare, whether they can have access to healthy foods, the things that I think really underpin much of the disparities that we see. So back to you about, what you think the current version of the prevent equations where race is eliminated, but I think we have these other strong predictors that can take its place and really, remove this concern about race being used as a biological construct.
Thanks, Don. As you mentioned, one of our goals was to really think about what are those other variables that we can perhaps measure that are universally or more available now today. And we really thought the social deprivation index, which is measured at the zip code level in these equations, could help to be a first step forward. It, of course, doesn't get at those individual level social determinants of health that we know play an important role in not only risk for hypertension, for example, as you mentioned, or heart disease, but also in being able to get optimal access to care and evidence-based therapies to reduce that risk. The social deprivation index was a nice first step forward to be able to allow a place-based measure. And we know the importance of the environment in which people live can also influence their risk for heart disease and starts to move us on this path towards more individualized and personalized risk prediction that accounts for not just these biological factors, but also social factors that together influence an individual's risk. So I think and hope that we continue to iterate on these and dig deeper into these social and environmental factors that we know contribute to racial disparities and better assess risk so that we can deliver the right therapies to the right patients at the right time and really be able to move towards a risk-based prevention algorithm that accurately and precisely estimates risk for each person. And so maybe, Mitch, I will turn it back over to you kind of and how we think about this really for stroke specifically, as well as for managing racial disparity is in stroke.
Sure. Well, let me just add, first of all, Sadiya, apart from the prevent equation project, the American Heart Association is actually doing a 2-year research project, which is partly funded by the Doris Duke Foundation, to explore how we go about assessing the impact of race in risk algorithms and how we move towards a more individualized approach to doing so and address those social determinants of health. So I think the field as a whole, the risk prediction field, clinical epidemiology, clinical care, have moved towards this different approach towards accounting for the effects of race and looking at those more detailed aspects. So I think it's important for the stroke community to know about those changes as well. And hopefully we'll have some interesting results from that over the next few years. And along those lines, I think it's important probably to try to explain to people what those factors are that we're talking about. So we often hear the term, social determinants of health, social drivers of health is a term that people like to use now. You mentioned place-based, and we know that there's a lot of data available from people's zip codes or census tract information, even more detailed than zip codes. We know that where people live, work, pray, play, these things that people do, the location that they do it in is so essential. And that's because that's tied to things like quality and availability of education. What is the neighborhood like? What is the housing like? Are there opportunities for getting physical activity, getting exercise in parks and so forth in the community? What is the air quality like? Is there a lot of pollution? Even water quality is important. We know that from several examples in the United States recently. What is the access to care? We talked about this before. Do people have insurance? Do they have doctor's offices and clinics, maternal care, infant care, and so forth in their neighborhoods? These are all crucial elements to being able to lead a healthy life and getting medical care when it's needed. And so these are the things that are driving, it's those specific factors that are driving the healthcare outcomes in many cases. And so getting those things into the risk algorithms is a challenge. The data, I think, have been limited. I would love to hear a little bit more about how the prevent calculators actually go about doing this. You mentioned the SDI, the Social Deprivation Index, how that's linked to location. But as we go forward, first of all, one thing that I think it's important for people to understand is that these risk calculators, unlike the pooled cohort equations, are based on, to a large extent, electronic health record data, right? And so as we're getting better and better at putting all those social determinants of health, like where you live and what is the nature of the neighborhood and so forth, into the electronic health record, and then we're able to mine that data to see how it relates to subsequent risk. So what impresses me so much about the work that you've been doing is that it's based on these enormous data sets that have the kind of data we didn't have, I don't know, certainly 10 years ago, maybe not even 5 years ago. It really seems like a fundamental advance to me. Can you say a little bit more about that aspect of it?
Thanks, Mitch. And I think that really underlies the importance of being able to target the derivation of these equations in the populations in which we want to apply them. And so one of the things about the availability of these large clinical health system data sets is that we're able to access contemporary data, able to derive the equations in the populations in which we want to apply them and have a diverse sample and be able to follow individuals and understand the risk for events on the background of current therapy. A lot of things have changed in the last couple of decades. And as Don mentions, the associations between risk factors and outcomes remain constant, but the background therapies change, the prevalence of risk factors have changed, and being able to leverage these large data sets that have contemporary and diverse populations really are helpful in being able to develop accurate and precise estimates for risk, because that really kind of translates into the next step of being able to communicate this with patients. How do we help inform patients what their risk is over the next 10 years, over the next 30 years, and think about what are the potential interventions or prevention strategies needed to then lower that risk?
Hmm. Well, that's great. And just again, as the stroke neurologist here, I actually want to hear from you, Don, a little bit more about, one of the things I think is so interesting about these equations is that now you've decided to also include heart failure as an outcome. And can you tell the stroke community why it's so important to include heart failure too. I mean, I think there's a lot more of it than there used to be, but can you tell us more about what's going on in the world of heart failure?
Sure. Thanks, Mitch. I think you outlined this nicely. This has been an evolution, right? The concept of risk-based prevention strategies really came to the fore in 1996 at a Bethesda conference, and it was incorporated starting in the early 2000s into many of the cardiovascular guidelines. But as you pointed out, those are really focused on preventing coronary heart disease. Well, that's good for men, and particularly actually might help prevent disease in white men. But we realized as things evolved that we were kind of leaving many important events on the table and leaving important segments of the population behind. And so one of the evolutions that came about, as you pointed out in 2013 with the Poole-Cote equations, was we added stroke as a very important outcome, because very often stroke is the first event, not a coronary event, but stroke in women and particularly in Black Americans. And so we felt it was very important to represent that risk. We can prevent these events with things like statins and blood pressure lowering therapies. And so understanding the risk is a really important foundational element of who we want to decide to treat. But as time has gone on, and we've seen really remarkable strides in preventing heart failure events as well. You pointed out, Mitch, heart failure is becoming much more prevalent in the population. As people are living longer with obesity, with chronic kidney disease, with actually after coronary events, we're actually perhaps becoming somewhat victims of our own successes. These are people who might have not have survived those events previously, but now are living to develop myocardial dysfunction, whether that's systolic heart failure with reduced ejection fraction, or even more commonly now, heart failure with preserved ejection fraction. People who've had long-standing exposure to obesity, to hypertension, that leads to heart failure with preserved ejection fraction. So this has really become an epidemic related to the successes of preventing death related to upstream cardiometabolic problems, but also just the prevalence of obesity and hypertension and diabetes in the population. And so we really felt that it was time to include heart failure as something that needed to be in the risk prediction equations, because not only is it becoming more important, we actually have great therapies now that help us prevent heart failure. And just over the last 5 years, we've seen remarkable data coming from randomized clinical trials that treating people who have diabetes or who have chronic kidney disease with something like an SGLT2 inhibitor prevents heart failure events quite remarkably well. And as we learn more about these, we know it prevents both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So, I think having those tools in the armamentarium and thinking about extending this risk-based prevention paradigm not only to atherosclerotic events, both cardiovascular and stroke, but now also heart failure, really makes sense, because some of these medications are a little bit expensive still. So you want to make sure you're deploying them in the people who are likely to achieve the best benefit, and those are the people who are at higher risk. So I think this fits really nicely into our paradigm. It's great to have heart failure, as part of the group now, not only, again, because we can predict it better, but we can also prevent it better. And I think that's a really nice step forward in these prevent equations. And I'll say that, the prevent equations were really designed to plug right into current guideline recommendations. If you look at primary prevention of cardiovascular disease guidelines, and even the most recent heart failure guidelines, they're all focused on this risk-based prevention strategy. And the prevent equations, I think, address exactly what those guidelines are asking for. And so a clinician can use them today to predict risk, start a conversation with their patient, and plug them right into the recommendations that then flow in those guidelines for risk-based prevention. So this opens up a Pandora's box, though, in a sense, right? So we've added stroke, we've added heart failure. Should we have added other things? Are there other things we should be thinking about that are important? And, Mitch, I think many of my patients really worry about, beyond just stroke, what about cognitive decline that might happen with aging? Is that preventable? What about dementia, whether that's vascular dementia, Alzheimer's dementia, or other forms? Are these preventable things? Should we be thinking about trying to predict and prevent those things as well?
Oh, yeah. So I would say, yeah, that discussion of heart failure, I think, is very relevant to the way that at least I think many others have been thinking about cognitive decline and dementia itself. And, in many ways, I think those are a form of brain failure over time. And we know that many of those same risk factors for heart failure that you just described, like diabetes, like obesity, which are so prevalent and increasing in the U.S. and globally right now, right? I think this is going to be the big public health problem of the next few decades, kind of like smoking was 30 years ago. That's what obesity and diabetes are going to leave us with in the next few decades. And they are risk factors for cognitive decline and dementia, as well as is kidney disease. And it's not a surprise that the things that cause strokes can also lead to dementia. You mentioned whether it's Alzheimer's disease, whether it's vascular dementia. I think in the stroke and dementia communities, it's increasingly recognized that there's overlap between these. Very few people, when they die and have pathology done, have only Alzheimer's or only vascular dementia. Most people have some combination of factors, and the same, what we call vascular risk factors are also risk factors for neurodegenerative disease. And they may accelerate the amyloid deposition of Alzheimer's. They may accelerate neurodegeneration in general. They may hinder the ability of the brain to clear abnormal proteins and toxic elements. We know the brain doesn't work well when the body isn't working well. We have to think holistically about the brain, the heart, and the body. And so I think for sure, I think we have to think carefully about how we go about including these other things like dementia into our risk calculations. I think you're absolutely right that most people, you mentioned your patients, if you do surveys of the general public, people are if you say, what disease, what condition are you most worried about? They don't say a heart attack. They don't say heart failure. They don't even say cancer. They don't say stroke. They say dementia, and just like you described, as we get better at treating people's acute coronary events and they survive and go on to have heart failure, they also survive to have dementia and related problems, functional decline, incontinence, gait disorders, etc., as they grow older. And so, there's a lot there, right? There are a lot of different aspects of aging and this process of frailty and decline. So how we measure those, what data we can use to access it. Maybe the electronic health record data will provide the detailed clinical information we need to create those outcome measures. But I think that's absolutely right, that we're going to need to think about, that'll be your next project. The next iteration of this, I think, will be figuring out how all those things figure into the outcome. But I think that the stroke community and the neurology community will be right there with you and would love to see that happen. And I hope that, this is a great example of where I think, the cardiovascular community and the neurology community can work together to develop those algorithms and figure out how to optimally implement them. I think it'll be really exciting.
It's good to hear that I'm going to be employed for a while yet to come, Mitch. Thanks for that.
Yes, I'm sure you will. Can I? I just want to ask one other question. Yeah. Since how often do I get you both in a webinar like this? This is a little bit off topic. I was very excited by the recent results showing that the SGLT inhibitors and GLP-1 agonists, that these new drugs, not so new now maybe, but now showing that a benefit in reducing cardiovascular outcomes, not just in patients, with diabetes, but in patients who have obesity and cardiovascular disease. And, recent results presented at the AHA scientific sessions, the SELECT trial, for example, other related trials as well, and more to come. But when I think about this, for the stroke community, and this is secondary prevention perhaps, because to get into the SELECT trial anyway, you had to have obesity and cardiovascular disease. And so I'm just wondering, most patients with cardiovascular disease do have obesity. And obesity is extremely common, right? So 40% of the population are obese, another 30% are overweight, right? Just incredibly high numbers. And so, stroke doctors, I think, are going to need to know about this too, because essentially, if you have a stroke and you're obese, would you argue then, Don, Sadiya, that those patients should be treated with one of these newer weight loss agents?
So it's a great question, Mitch. I think these are really transformative, potentially transformative results that you're talking about from the SELECT trial. And you described the results nicely. Really quite remarkable reductions in cardiovascular disease events by using a medication, a GLP-1 receptor agonist, semaglutide, which actually is focused on initially diabetes care, but also weight reduction. We know is quite a prominent feature of use of these medications. I think what was striking about the results was that not only did they directly reduce cardiovascular events, but they seemed to kick in maybe even before we would have expected the weight loss aspects to actually be prominent among them. So these drugs are working potentially through additional pathways, but don't discount the way these things work, right? So yes, they drive through weight loss, but the early effects, the intended effects, not side effects, but intended effects of these drugs is to suppress appetite. And so when people change their eating habits, you can see remarkably quick changes. Remember, when you reduce your caloric intake, one of the things you're also doing is reducing your sodium intake. And that can have very rapid effects on things like blood pressure, on other aspects as well, that can lead to pretty early changes in risk factors that can reduce risk as well. So, I think that we have a lot to learn about why and how these drugs are working. But just as cardiologists, I think, have had to get very comfortable with using SGLT2 inhibitors, nominally a diabetes medication, but really a cardiovascular medication, I think all of us who deal in the cardiovascular field are going to have to get much more comfortable with using these GLP-1 receptor agonists, not just for weight loss, but also thinking about them as part of our prevention armamentarium. They're expensive. They're not so easy to get right now. And so we have some barriers to them. And I don't think we're going to treat absolutely every single patient, with these. I'd still push, good old-fashioned lifestyle first. But I think it is really nice to have these as, another arrow in the quiver. And Sadiya, you've thought a lot about these medications. I'd love to hear your thoughts as well.
Yeah, no, Donna and Mitch, I think I completely agree. It was really exciting to see the results of the SELECT trial at scientific sessions to think about another therapy that can further reduce that residual risk. So these were patients with cardiovascular disease that were very well treated. They were on optimal evidence-based therapies, and we still saw an added benefit, I think, to Don's point, and that benefit came really early in the trial where the curve separated very early on. So that was very exciting. And I think one other piece to amplify that Don mentioned, that these were originally diabetes drugs, that they do cause weight loss, but we have to move beyond thinking of them as diabetes drugs or in general of drugs as kidney drugs or obesity drugs. And I think really focus on this holistic approach to patient care to reduce cardiovascular and stroke risk. And if we communicate in that way and address risk in that way, then I think we can set up a roadmap for how we then treat the right patients with the right therapies. Cost, I can't emphasize enough how important that is going to be, especially as we think about equitable access to these therapies and ensuring that we do not widen disparities in care and in cardiovascular disease outcomes for new therapies like this.
Mitch, that was a great segue because I think, we're continuing to have more and more things that will help us prevent cardiovascular disease, stroke, and heart failure events. And, we saw many, many other new therapies that are working their way through the pipeline, phase 1 and phase 2, and now even phase 3 studies that I think will, attack some of the other longstanding problems that we've had, lipoprotein little a, other approaches to lipid-lowering therapy, long-lasting vaccine approaches, if you will, to blood pressure coming through the pipeline as well. We'll see if those remain as safe and effective therapies for lowering cardiovascular risk. But the armamentarium is really growing substantially. I think risk-based prevention continues to be an important paradigm to think about who would best benefit from these potentially expensive and these different types of therapies. So that's why I think the prevent equations continue to be extremely relevant, within this overall paradigm. We've talked about some of the outcomes, and you talked beautifully about the importance of cognitive function and dementia. But I don't want to only, highlight the outcomes that are different about PREVENT. We've talked also about some of the inputs, the variables that are used in the PREVENT equation. And Sadiya, if you talk a little bit about some of the things that are new in the base model of these equations, but also some of those things that can plug into the equations that clinicians may have measured because they're clinically indicated, that can also enhance the risk prediction.
Yeah, Don, thanks for asking that. One of the things we wanted to think about are in the base model, what are the variables that are readily available to any primary care clinician that could be plugged in, or other treating physician, cardiovascular physician, stroke physician, family practice, that would be seeing a patient for primary prevention. And so the sex-specific models for the base equation include age, and then the traditional risk factors that we think about: blood pressure, cholesterol, diabetes, tobacco exposure, medication use for high blood pressure or statin use. But we also included EGFR for kidney function in that base model as a variable that's readily available and can help us better understand risk. We then set aside 3 additional or optional equations if available or indicated. For example, hemoglobin A1C in a patient with diabetes or when indicated for screening. UACR, or urine albumin creatinine ratio, when indicated particularly for patients with chronic kidney disease, diabetes, or hypertension. And of course, we've talked about the social deprivation index having an additional input as well. And we wanted to set it up in the sequential way: if a variable wasn't available or wasn't indicated, that the base model would still be able to calculate risk and be able to be communicated with patients.
Can I ask, you said you have a few different options for models, and some you'll use in some settings and others in others, when indicated. I'm just wondering about how you both see implementation of these scores. It sounds kind of complicated, perhaps because I'm a stroke neurologist, but it sounds complicated. How do you see this, the doc in the office utilizing these? How easy will it be?
Yeah, the goal is to make this as easy and straightforward as possible, both for the clinician, but also for the patient. I think the important part of kind of having these risk estimates is really a push towards that advocacy of understanding risk and being able to communicate it well. Some of the things regarding the optional and the add-on models can be done on the back end. So I think making sure that the kind of online tool allows people to enter the information they have and still be able to calculate a risk, and as well as use it as a potential implementation tool to suggest your patient has diabetes, has a urine albumin creatinine ratio been checked, because we know that that is really an important predictor and marker that should be routinely screened for among people with diabetes, but often isn't. Don, would you add to that in terms of how to think about implementing and integrating PREVENT into clinical care?
Yeah, that's right. And we've definitely seen a lot of experience with this, with things like the pooled cohort equations, where the online tools, I think, can be a great starting point for clinicians to get familiar with how these things work. But the front end is put in the data that you have. The back end is, okay, if you didn't have that, we'll use the equation that doesn't require that particular variable, like UACR, if it wasn't indicated. So either way, the clinician will get the output of, here's the 10-year risk, here's the 30-year risk for this patient's situation. So I think that's a great starting point. But, I think what we've seen evolve, and you mentioned electronic health records earlier, is, that typically at individual institutions, people will create the equations and create, if you will, a dot phrase or a simple shortcut so that the actual electronic health record for that patient is mined for the data. The clinician doesn't have to go looking for it, and it'll automatically appear in the patient's note, or if the clinician wants to calculate it, as they're doing their workflow. So that can be a huge time saver. You don't have to, in that case, go to the web and plug in numbers. The electronic health record will mine the data that you need, and the calculation can happen automatically. I've got that built into my current notes for the pooled cohort equations, and I'm looking forward to building it into our platform for the PREVENT equations as well. I think it really helps me save time just to do that before I go into the room with the patient and say, oh, okay, So I'm going to have a much more detailed discussion with this patient because they're not low risk. They're actually high risk. And there's somebody who I might want to walk through consideration of different preventive therapies, thinking about, are they at more risk for heart failure? Are they at more risk for atherosclerotic events? Or should our focus be elsewhere? So it's a really helpful way for me to frame a visit with a patient, doing that calculation beforehand. And if the electronic health record can do it for me automatically, boy, that saves me a lot of time. So I think there are a number of different ways these can be implemented as both time savers, but also to improve patient care. And that's exactly what we're rolling out with the Prevent equations. And I think it's going to be an exciting step forward.
Yeah, it sounds like it. So there's opportunities for clinician decision support, I guess, being tied to these equations. That's really terrific.
That's right.
Let me ask you one other question, which I think is probably on the minds of stroke doctors, which has to do with atrial fibrillation. We think of atrial fibrillation as, obviously a major risk factor for stroke, especially as the population ages. 20% of people in their 80s and older are going to have AFib. It causes the worst kinds of strokes, the big embolic strokes that are so disabling and so forth. And yet, I'm not sure AFib is like part of the risk calculation. It's certainly in all the stroke risk calculators, but when we start looking at risk of cardiovascular disease overall, where does AFib fit in all this?
Yeah, it's a great question. I think AFib kind of sits in a little bit of a gray zone, as you're pointing out, right? It is an important outcome in and of itself. It's not particularly easy to predict who, and especially when, someone is going to get atrial fibrillation. And so, there aren't really good risk prediction equations for the onset of atrial fibrillation, even though in and of itself, it is an important cardiovascular condition. As you point out, at the same time, atrial fibrillation is also a major and proximate risk factor for stroke, especially, but of course, other embolic events. So it sits in between these things. And, I think we didn't include it as a risk predictor variable, if you will, in part because we don't detect atrial fibrillation very well. So there's not a lot of accurate or precise measurement of who has atrial fibrillation at any given time. And anytime a variable is not measured particularly precisely, it's not a very strong predictor, in these kinds of equations. But I think the other issue is that, when we do detect atrial fibrillation, it's not a risk-based, it's not so much of a risk-based decision. That patient needs to be protected from the risk of stroke that is attendant to their atrial fibrillation. So, we use the CHADS-2 VASC score in that setting, imperfect, but, a reasonable approximation, a good place to start. To decide whether someone needs, direct anticoagulation rather than just, watchful waiting. And, so I think the decision making is somewhat different rather than pure continuous risk-based estimation as a starting point. It's, do they have atrial fibrillation or not? And if they do, if I've detected that, then, are they at enough risk that the benefit of anticoagulation is going to outweigh the risk? So in some ways, the thinking is the same, but it doesn't quite fit into the same prevention paradigms that we're using, for example, with decision-making around statins or blood pressure medications or heart failure prevention medications like SGLT2 inhibitors. So it's still a little bit of a gray zone. It's a really terrific question and does not mean to belittle the importance of atrial fibrillation. It's crucially important, especially for stroke prevention. But I think the real issue there is not, can we predict atrial fibrillation onset? It's more, can we do a better job of detecting people who are having AFib events and getting them on anticoagulation when it's appropriate?
I think that's a really great point to amplify that last piece that you said that really is the deciding factor, I think, in how we think about risk prediction for AFib is the detection. And so it's exciting to think about some of the new studies that are being done and coming out in terms of wearables, particularly in risk-enriched populations. So perhaps instead of thinking about the risk-based prevention paradigm, we want to really think about risk-based detection for atrial fibrillation, and that might help bring it into a little bit of a better place to be able to say, if we know who's going to get atrial fibrillation or we can better detect it, then can we predict it?
Yeah, no, that's great. Well, I've really enjoyed talking with both of you. I've learned a tremendous amount. I hope the audience does too. I don't know if you have any final thoughts, Sadiya, about PREVENT? What would be your take-home message to a busy neurologist who's passing through the International Stroke Conference? What do they need to know about PREVENT in just a couple of sentences?
Well, thanks, Mitch. This has really been a really fun conversation, and I think you said it, just the chance to have all three of us together in one place at one time, being able to discuss some of these topics. Yes, a virtual place,
Yeah.
being able to discuss some of these topics that are really relevant to optimizing patient care. And so I think the thing that I would want people to take away is that the prevent equations are another tool. We hope that they are a good tool to be able to really communicate risk to our patients to optimize their care and outcomes. So hopefully this allows a structure or platform to be able to identify who's at the highest risk for stroke, for cardiovascular disease, for heart failure, and then allow clinicians to better have a shared decision making conversation about what are the options that are available to then reduce that risk. And as we have the web calculator online to be able to readily implement that into their practice, as well as Don mentioned, being able to provide plugins for electronic health records so that this is automated and helps also facilitate those communications and conversations.
Yeah, and I might just go beyond that. I mean, the prevent equations I think are a really important step forward, but just the broader construct, the framing of thinking about CKM syndrome, cardiovascular disease, vascular changes, the metabolic impact of obesity on diabetes risk, and so many other aspects of risk that affects numerous health outcomes, brain, kidney, heart, liver, and beyond. All these things are so intertwined that I think this new construct of CKM syndrome and thinking about the spectrum of cardio-kidney-metabolic health across the life course, I think that's a really important step forward as well. It reminds clinicians that we are not just looking at a single organ system, right? That, yeah, I'm a cardiologist, but I got to think about brain health. I have to think about liver health. I have to think about how, kidney function may be affecting, the things that I focus on most every day. So, taking that broader perspective, thinking about stage 0 CKM, primordial prevention, don't let the risk factors develop in the first place. Stage 1 in this CKM syndrome, patients who are adding weight, unhealthy weight, that is going to lead to further metabolic outcomes. Stage 2, where the actual, interposing risk factors start to develop, hypertension, diabetes, dyslipidemia, some of these other things. And then stage 3, where we have clear subclinical disease. These patients now are on the fast track. They have evidence of plaques in their arteries. They may have evidence of left ventricular mass increases. They may have evidence of chronic kidney disease. Even if we looked, they might have white matter lesions or other things that we can already see in their brain. They're on the fast track then for those acute clinical events, stage 4, that really lead to both disability, but also mortality, of course. So thinking in this broad contextual framework of CKM syndrome and CKM health across the life course, I think can help all clinicians, all patients understand the interconnectivity of our different organ systems and why we need to really focus on health at every stage of the life. And of course, especially upstream, hopefully launching children into healthier trajectories so that they don't transition from stage 0 to stage 1 in the first place. So, I hope people will take the time to read the presidential advisory and the different scientific statements that have come out, really framing this new context, this new construct of cardio-kidney-metabolic health, because I think it really will change their thinking and help them look at their patient more holistically and not just as a single organ system.
Yeah, that's so well said, Don, and I couldn't agree with you more. I think about kind of where the Heart Association started, perhaps 100 years ago, in terms of thinking about the heart. And over the last century, it's really I think of it as an expanding sphere in the sense that, as you've just mentioned, we've moved out from the heart to stroke and the brain, and now to the rest of the body. The CKMH paradigm says adiposity and obesity are kind of central to the development of these other downstream risk factors, hypertension and diabetes and so forth. And these really affect the entire body. So thinking holistically within the body is important. And at the same time, as we've heard from Sadiya in the prevent risk calculator, we're thinking about the social determinants of health. So we're also expanding outside of the individual person to the family, the community, the society, and environment, and how those influence disease too. It's, the health of an individual is dependent on so many things, within their body, throughout their body, and also throughout the world in which they live. And it's complex, but I think it's important to think about all those elements if we're going to make progress. And I guess just as a final thought, for this community, certainly in this process of the evolution, as you described before, of these risk prevention schemes, those also, began with the heart attacks, perhaps, expanded to include stroke, heart failure now, and I think it'll be exciting to consider how we include these other outcomes like dementia into the long-term picture for risk prediction and better care for our patients. So just my parting thoughts on this. I really enjoyed the discussion. Thanks, guys.
Thank you.
Thanks so much.